Hello, my name is Dr. Dewan S. Raja. Today I will discuss about Dharmatome. What is Dharmatome? The area of the skin supplied by a single segment of the spinal cord, therefore by a single spinal nerve, is called Dharmatome. This is the unilateral area. We have two sides, two, two spinal nerves, so we have Dharmatome on both sides of our body. In the trunk, the dermatomes extend around the body from posterior to anterior, from posterior median line to the anterior median line. Each dermatome begins posteriorly overlying the intervertebral foramen. Intervertebral foramen is the passage for the spinal nerve, and it is the area where we'll get the dorsal root ganglion. So these are the dermatome, this stripe on one side and also on the other side. These are the area of the skin innervated by a particular segment of the spinal cord. Okay, so these are the dermatome. If we just think this way from our history of evolution, okay, so this is the position here in the four-footed animal. Okay, here is the C2. We have no C1 dermatome because the the C1 has no cutaneous innervation for the skin. Okay, we have the C2, C3, C4, and if we just think the upper limb that developed from the limb bud, so the lateral aspect is above, and the medial aspect of the upper limb is below. Okay, so from C2, C3, C4, if we continue, we'll get C5 on the arm area, C6, we'll get C7 that covers the the forearm here, C7. Okay, then we'll go to the C8 on the other side. The little finger will get the C8 here, C8. Okay, then again T1, and very close to the axilla will get T2. Okay, so C5, C6, C6 is coming to the thumb area. We'll go there gradually. Okay, and the perineal area, the dermatome should be S2, S3, S4. In the adult, we have seen in this image, spinal cord is smaller than that of the length of the vertebral column. Okay, so when we assess the dermatome, when we assess the spinal cord segment, we will assess the spinal cord segment and dermatome accordingly. Here is the end of spinal cord. The vertebral column is up to this. Okay, so dermatome is very essential to assess some neurological diseases. Dermatome is very essential to inject local anesthesia. Okay, dermatome is also essential for other purpose like that of the site of lesion, as well as to assess the referred pain. Suppose there's intercostobrachial nerve T2, the lateral rami of the T2, that is called intercostobrachial nerve, that is associated with cardiac referred pain. Okay, so like that way, so it has multiple use to assess neurological diseases, to inject local anesthesia to numb the area for any type of surgery. Okay, and also to assess the referred pain. Okay, so we have to remember these levels of principal dermatome. There may be little overlap and there may be little variation from person to person, even variation from textbook to textbook. I'll request the students to learn the this level of principal dermatome, and please confirm from your textbook what is your textbook in your medical college. according to that. Suppose C2 for the back of the head, C4, C5 clavicle. So back of the head, because our forehead area, the up to vertex, it is the dermatome from the ophthalmic division of trigeminal nerve. Back of the head, C2, then C4, C5 clavicle. Mostly C4 is covering the clavicle. C5 may come on the lateral aspect of the clavicle. C5 upper and lateral aspect of the arm. So you have to remember that in anatomical position, our thumb is lateral. Okay, so the upper and lateral aspect of the arm, C5, C5, C6, C7, lateral aspect of the upper limb that include the upper limb, that means the arm and forearm, T8, and the C8 and T1 medial aspect of the upper limb. It includes the little finger plus the forearm, part of the arm on the medial border, that is the ulnar side, medial border. Okay, in anatomical position, our hand is like that way. So this is the medial border, that is the lateral border. Okay, we got that. So for thumb and lateral aspect of the forearm, the dermatome is C6, C7, C6, C7, C8 for the hand. For hand, C6, C7, C8. C7 supplies the middle and ring finger. Middle three finger maybe. There may be some overlapping. There may be some variation. So certainly the middle finger, C7, and the C7 and the ring finger, maybe half of the ring finger, but the middle finger is total. Okay, it varies from person to person. T1 medial forearm and arm. So medial forearm and arm. Okay, T2 nerve supplies the small part of the arm and the skin of the axilla, especially the floor of the axilla. Okay, so that is very important. The lateral cutaneous branch of the T2 is called the intercostobrachial nerve, and that may be associated with cardiac referred pain. Not only the T2, sometimes T1 may be affected, may be involved in cardiac referred pain, and that is very important. Okay, T4, level of nipple. We must remember that dermatome will not change. Level of nipple, okay. How about the level of nipple of an obese lactating mother? Is it different? No, it is same as that of of a small girl. She has also T4. So the dermatome will be remain as T4. The position of the breast may go down, okay, depending on the functional status of the breast and the obesity or on other conditions like shape, size. Okay, we'll go to the T4 level. We'll add one more, T6 for the xiphoid process. We'll add one more, T6 for the xiphoid process. Part of T5 may come close to the xiphoid process, but the tip of the xiphoid process of the sternum, that is the dermatome, there is T6. Okay, T10, level of the umbilicus. Umbilicus very important. We may have some appendicitis, appendix inflammation. Then in case of acute appendicitis, we may have referred pain to T10 level of the umbilicus. L1, inguinal or groin region. Okay, so this here, L1 may be divided into two, iliohypogastric, ilioinguinal nerve. Ilioinguinal nerve will be the nerve for the inguinal region, also the root of the penis, okay, or area of the mons pubis area in female. L1, L2, L3, L4, anterior and inner surface of the lower limb or inferior extremity. Okay, L3, kneecap will go to the medial aspect of the kneecap. L3, that will be more perfect. Okay, so and also physician do the jerk test, knee jerk test. They hit the ligamentum pettili. They assess the L2, L3, L4 because quadriceps femoris muscle is getting innervated by the femoral nerve. Its root value is L2, L3, L4. Our dermatome on the kneecap is L3. L4, L5, S1 for the foot. Okay, we'll look at the image. L4, medial side of the great toe. Okay, S1, S2, L5, posterior and outer surface of the lower limb. S1, lateral margin of the foot and little toe. So for the greater toe or the great toe, it is L4, but for the little toe, it is S1. And for perineum, S2, S3, S4. Okay, we'll just compare this image with that of the previous one. Here we'll get the idea. Okay, S2, S3, S4 for the perineum. Okay, from the back of the head, C2, then C3, C4. Okay, that cover the clavicle area and the nape of the neck area, upper part of the nape of the neck area, and C5, C6. We have C7. Then it is going in that direction. C8, T1, here T2. Okay, we got that. Okay, we learn more according to our images. Okay, so I will request everyone to learn this principle Dharma Term. Okay, so what is Dharma Term? Again, what is our different type of definition? Same definition in different way. A Dharma Term is the area of skin supplied by the sensory fibers of a single dorsal root of a single spinal cord. Okay, dermatomes are important to understand. We have just discussed that. Okay, embryological is important. What is dermatome? Dermatome are derived from somite. What are somite? These are paraxial mesodermal tissue block. Tissue block. Okay, so from that paroxysmal paraxial mesodermal tissue block will have three components. One is sclerotome that will develop into axial skeleton and cartilage. There is the vertebral column and associated cartilage. Myotome, part of skeletal muscle. That also myotome also get the innervation from a particular spinal cord, but it gets the motor innervation. And multiple myotome forms a big muscle. Okay, dermatome, what we are putting more emphasis here from dermatome, that is a part of somite, a derivative of somite, a component of somite that will lead to the formation of dermis and subcutaneous tissue. Okay, we got that. Now we'll go to that dermatome here. Okay, we must know that spinal nerve C1 lacks the significant efferent component and does not supply skin. It picks up some of the proprioceptive sensation from the muscles of the neck, intrinsic muscles of the neck. Okay, but there is no skin innervation, so there is no C1 dermatome. C3, C4 supply the base of the neck and supraclavicular region, especially like this from the clavicle here. C3, C4, clavicle mostly C4, partly C3, maybe sometimes C5 may come close to it. Okay, but it is C3, C4. Okay, we got that. Dermatome of the face is mostly carried by the trigeminal nerve. So this part, forehead, vertex area, from the V1, ophthalmic division of trigeminal nerve, including the, the roof of the nose, plus upper eyelid, plus the conjunctiva cornea. There is the ophthalmic division of trigeminal nerve. Then we'll get the maxillary nerve here, below that, lower eyelid, and this part of the cheek. There is the maxillary nerve. Then this is the mandibular nerve that includes the mandible. Okay, maxilla part of the skin supplied by the maxillary division of trigeminal nerve. This is the mandibular division of trigeminal nerve. It is the dermatome for the lower part of the face. Just the angle of the mandible will get the great auricular nerve C2, C3. at the angle of the mandible. Okay, T7 to T11 anterior remiothoracic spinal nerve are called thoracoabdominal nerve because they courses from the thorax to the abdomen. They go from between the second layer and third layer of muscle. Okay, we got that thoracoabdominal nerve. Then dermatome of perineum is very important. We must remember that it is S2, S3, S4. Okay, so if you look at the labia majora area, it is getting S3, S4. Here we're also getting S3. Here is the S4 area. This is partly innervated. Cutaneous innervation is carried by the L1 ilioinguinal nerve. So we'll have the line of demarcation, discontinuity of the dermatome. Okay, discontinuous dermatomes are in close proximity. Here L1, here we have the S3. Okay, like L1, S3. Okay, that is called axial line. The line between the discontinuous dermatomes when they come in close contact. Okay, so that is S3, S4, S2, S3. This is S3. So that is the just at the root of the penis we may have contribution from ilioinguinal nerve. Okay, otherwise it is S2, S3, S4. Okay, like that. Here is also ilioinguinal nerve at the upper part of the labia majora. Okay, we got that. Now we'll go to the dermatome, segmental pattern of the skin, innervated and is retained throughout the life. So the dermatome here, the nipple is T4. The dermatome here in a female who is lactating, he is large breast and obese lady, still the dermatome of the nipple should be T4. The xiphoid process should be T6 here. Okay, maybe partly T5 go down here. So we go there 7, 8, 9 above the umbilicus. Okay, then 11, 12, L1, these are the below the umbilicus. Okay, axial line, line of junction of dermatome supplied by discontinuous spinal nerves. There are no overlaps. Okay, so there are no overlaps there. Discontinuous spinal nerve like that of the L1 and S3. We've gone through that part. Okay, here is L1, S3. Okay, this is the axial line. We may go through this way. Okay, so we got that. Now we'll go to the dermatome of the limb, upper limb. Okay, there may be some little variation. This is C5, C6, must remember, thumb C6, little finger C8. Okay, the middle finger C7. There may be the half of the ring finger may be C8 also. Okay, like that of this. Hand area, we have the 6, 7, 8. That is the dermatome for the hand. Forearm, lateral border, C6, C5. Medial border, T1. Here is T1. T1 is the middle border. Above that, we'll get T2. Like leg area, kneecap, medial aspect, L3. Maybe partly L4 here. L2, L3, L4. Okay, the great toe is L4. We got that. Then lateral aspect, the peroneal or fibular aspect, we have the L5. Okay, heel of the foot here, the calcaneus area is S1. Here, S1. Okay, lateral border of the foot is the S1. We have to remember that part. Okay, then again S3, S4 is here. This part is L3. Okay, we got that. Now, again, we have to remember that dermatome of the face is done by the ophthalmic nerve. With exception here, angle of the mandible area, skin, here sensation is carried by the great auricular nerve, root value C2, C3. The upper eyelid dermatome is the the ophthalmic nerve. Okay, the maxillary area here, dermatome is the dermatome is the maxillary nerve, mandible area, dermatome is the mandibular nerve. The up to vertex ophthalmic nerve, including the roof of the nose, even side of the nose. Okay, you have to remember that part. Okay, then here behind the vertex, back of the head, the dermatome is C2, C2, C3, C4 the neck, C4 is going to cover the clavicular area. Okay, S2, S3, S4 for the perineal area. Okay, we have to remember that the thumb C6, the middle finger C7, the little finger is the C8. How about the index finger? Index finger is C7, index finger. Part of the ring finger is C7, part is C8. But always there is some variation from book to book, variation from patient to patient. Okay, here the thinner eminence mostly by the C8, then hypothenor eminence by the C8. Okay, here C6 here, it is C8. Okay, C6 thumb, the little finger, and this part, the hypothenor eminence is by C8. Okay, the index and middle finger, C7. We must remember that. Great toe L4, the little toe S1. The heel area, there is the calcaneum, here is the S2. Okay, we have to know that there is overlapping of the dermatome area. So when an anesthetist used to inject to numb a particular dermatome, he must inject at least 2 dermatome. Then he can anesthetize. Otherwise, there is always overlapping. Overlapping in the peripheral processes. This is the dorsal root ganglion. Even also overlapping in the central processes. So to anesthetize a particular dermatome, we must inject at least 2 dermatome by local anesthesia. That is the idea. Okay, we got that. Now, this is the herpes zoster. Herpes zoster, or also called shingle. This is very important to remember that this is a common problem. Herpes zoster is caused by the same virus that also causes the chickenpox. Chickenpox in the early age, then the DNA of that virus may remain in the dorsal root ganglion, maybe even in the geniculate ganglion, the facial nerve, or maybe in the trigeminal ganglion. But mostly it is the spinal nerve ganglion, the dorsal root ganglion, it may remain, the DNA or the virus remain there. When the person's age is advanced, or when he has some type of low body defense mechanism, low immunity, he's taking anti-cancer drug, he's psychologically very depressed, he's in malnutrited condition. In that condition, that virus flare up and passes along the axon, along the anterior and lateral branch of the spinal nerve. Okay, and it forms blister like this. Okay, this is the blister. So in the exam, if you ask a question, what is the dermatome here of this herpes zoster? T3. Nipple, what is the dermatome? It is the T4. Okay, now look another person. Okay, another person. What is the dermatome here? This is the ophthalmic division of the trigeminal nerve. Okay, this may happen in a person who has low immunity or suffering from some disease, maybe long-standing diabetes, maybe a patient of AIDS or any other very much bad disease, or he has very low immunity due to any reason, he is malnutrited, taking anti-cancer drug, then the virus may flare up from the trigeminal ganglion. Okay, and particularly like the ophthalmic division of trigeminal nerve, cornea may be affected, that may lead to blindness. Okay, so we got that, the herpes zoster or shingles. And that's all about the dermatome. If you have any question, please feel free to ask me, and please share the information with your friends. Please support my channel. Please subscribe me. And have a nice day. Bye now.